Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy and the Northern New England Association of Healthcare Executives. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Today's interview is with Tricia Cummings, the administrator of the Edgewood Center, a 150-bed family-owned nursing home in Portsmouth, New Hampshire. Tricia received both her bachelor's and master's degrees from the Department of Health Management and Policy here at UNH. Tricia's career story shows how early job experiences often generate skills that become critical later in one's career, and that working hard every step of the way has its payoffs. In this podcast, we talk about the road Tricia took to find her true passion, taking care of older adults. We also discuss how someone becomes a licensed nursing home administrator, the services offered by long-term care facilities, the challenges and opportunities facing long-term care today, and conclude with a discussion of opportunities for the early careerist who might be interested in pursuing a career in long-term care. The full podcast is approximately 83 minutes, which is a bit longer than our usual podcast. However, an abridged version is also available that only focuses on Edgewood's service structure and the challenges of long-term care, and is approximately 35 minutes in length. Welcome to the Forge, Tricia.
Thank you.
I want to congratulate you on being the first alumnus of the Health Management and Policy program to appear on the Forge. It's kind of exciting.
It's very exciting.
So, speaking of University of New Hampshire, how did you come to go to the University of New Hampshire, and how did you choose to major in health management and policy?
Okay, well, first of all, I'm a local girl.
Okay.
I grew up in Northampton, New Hampshire. My family has a history of attending UNH. My mother, as an older learner, went to UNH. My older brother, as well as my older sister, as well as a second brother, also went to UNH. So it seemed natural that I would apply.
Family legacy.
Exactly.
Okay. And did you apply as a health management and policy major, or did you come in and then kind of discover it?
Yep. So I actually came in as a health management and policy major, and I think at the time it was a relatively new major, and maybe isn't the best answer, but it is the right answer. The correct answer is that I was sitting at the dinner table on a Sunday evening, getting ready to complete my application, and my brother and my sister both said, "Oh, you want to pick a major. You don't want to go in undeclared. You got to pick a major." And I knew that I wanted something in healthcare. I just wasn't quite sure what. I think at the time I was kind of toying around the idea of becoming a physical therapist. And I very much remember that conversation where my brother said, "You know, I've heard that health management and policy is an up-and-coming major. You might want to consider that." And I said, "You know what? That sounds great." And I checked the box. And thankfully, as soon as I took the first class, I think it was Introduction to Healthcare Systems or something like that, as a gen ed. And it's still there. HMP 401, I think it was.
Right. That's right.
I knew immediately upon taking that class that I had made the right decision, and I've honestly had no regrets ever since.
How did you decide, how did you know you wanted to do healthcare? Is your family involved in healthcare?
Yeah, good question. So my mom's a nurse.
Okay.
And have just spent, my mother is just a caregiver by nature, and she was a school nurse here in Portsmouth actually for about 30 years. And so traveling with her, to the high school and seeing what she, had accomplished in her career. And also my mom has had a second job as a nurse in a long-term care facility. And so that was really my introduction into nursing homes.
So you had seen that environment already?
Definitely, yeah. Okay. And my mother's also one of those people who's just always had what I refer to as a person, somebody that she's just kind of adopted and just, taken extra special care of. And typically speaking, those people have been older adults.
Okay.
And so just watching her and knowing that I really liked being in that kind of environment.
Okay. So one of the things that is required for health management policy majors is to do an internship in between their junior and senior years. Where did you do your internship, and how did that influence kind of where you wound up?
Yeah, good question. So at the time I was in the major, the internship was actually the second semester of your junior year, so it was a full 16 weeks full-time. And I was lucky enough to be accepted at Exeter Hospital. And so I had just a wonderful experience there. And I think why it was a wonderful experience is I just wanted to be exposed to as much as I could be exposed to while I was, in that learning environment. I do think as a benefit it was an unpaid position, which I know sometimes might not be very popular. However, looking back, I can see that that was an advantage because then I didn't feel like I had to be productive in the way that I was making a paycheck, but productive in the way that this was truly just a learning opportunity. And so I took full advantage of that. Being connected with the CEO of the hospital opened up doors.
Right.
So I was able to watch surgery firsthand, right there in the surgical suite.
Was the CEO your preceptor?
She was.
She was, okay.
She was. It was Kevin Callahan.
Okay.
So title-wise, I guess maybe might not be speaking correctly. He was there,
Okay.
and he may have been sort of
Okay.
the CEO of the whole hospital system, but at the time they had a separate administrator for the hospital, Barbara
okay.
Grillo.
Okay.
And so she was my preceptor.
Okay.
And again, that just opened up doors. And so
Great.
I had the opportunity to watch surgery. I spent time in the emergency department. I got to watch a birth and certainly interviewed really just a whole host of people in the hospital about their jobs, and certainly worked on projects and things of that nature as well. But
Right.
I felt like it was a time for me to just really open up my eyes to see,
Yeah.
really
Sounds like you
what
really
went on.
took advantage of it.
Exactly.
Yeah.
Yeah, it was a great experience.
Okay. And I think you mentioned in an email that you also worked here while you were in.
I did, yeah. And so
how did that come about?
Yeah,
Was
it's
that
a great
related to the major,
question.
or?
Definitely related to the major. So again, the internship was that second semester of my junior year, and just seeing, what the possibilities would be, thinking it would be a good time for me to add something to my resume, thinking about graduation coming up, in another year. And so I decided that I wanted some more healthcare experience on my resume. They kept me on also at Exeter Hospital in the emergency department as a registration clerk, which looking back was probably one of the most interesting jobs that I've had because it was on the 3 to 11 shift during the summertime on weekends in a summertime kind of community. So it was super interesting. But I responded to an ad for a part-time rehab aide here at Edgewood Center, and just, kind of on a whim applied and ended up getting the job.
Okay.
And so started working, maybe 2 days a week, helping residents here with ambulation and range of motion, and just augmenting, the professional rehab staff with whatever they might need. At that time, you didn't need a certification, to do that job. So I was just, trained on the job and, fell in love, with the facility, with the residents, and continued to work here while I finished out my degree.
Okay. But your first job, actually, upon graduation from UNH with your HMP major, was with Harvard Pilgrim as an insurance underwriter. So you jumped into the business side rather than the patient care side.
Yeah.
Was this the kind of work you actually expected to do as a result of the major, when you signed up for the major, or how did that come about?
Yeah, well, I remember kind of being in angst a bit about what I was going to do and feeling like I needed to, get, quote unquote, a real job. And honestly, just putting applications out everywhere. I think initially upon graduation, I did have this expectation that I would go to work in a hospital and I would just immediately go into a management position just because, why wouldn't somebody think I could do that?
Sure.
And it was a conversation I had with Kevin Callahan. I went back to Exeter Hospital again, just sort of looking for some career advice. And I remember him saying, Tricia, don't worry so much about kind of where you're going right now. What's important right now is that you get a job, and that you just gather as much experience in that first job that you get to take you to the next job. And I was really happy that I did take that advice. And at the time, it was Harvard Community Health Plan, before all of the mergers.
Okay.
And they called me down for an interview for a position that I didn't initially apply for, but they'd kept my resume on file and called me back, and took a job as a non-group underwriter. Which truthfully I absolutely hated, hated, because I was leaving an environment like here at Edgewood where every day I'm interacting, with residents and their families, and, every single day feeling like I'm going home, that I really made a difference to somebody, a substantial difference. So I went from that type of an environment into an office situation where people are applying for health insurance, and a lot of times people are applying because they need health insurance. For instance, if a person is pregnant, as a simple example, and they're applying for non-group insurance, that's an automatic reason for denial. And so my first job I was responsible for those easy no's, either the easy no's or the easy yeses.
Okay.
And that was really hard for me at first, not only from an environmental standpoint, office, cubicle, phone, file type of situation, to then delivering news to a person who, needs help.
And you're saying, we're not going to help you.
We can't help you, yeah. And I get the whole rationale behind that. But at the same time, it wasn't necessarily an easy transition for me.
Okay. So you stayed there for 3.5 years. What was, aside from kind of the initial reviews, what what is an underwriter doing?
Yeah, so basically an underwriter's job is to make sure that the insurance company isn't accepting undue risk, basically, number one. And then number two, that I went from the non-group side that would probably more specifically relate to the risk of, medical risk, to the group side, which then combines risk with pricing. And so in that position, I was responsible for reviewing new groups that were coming or being proposed by the marketing department. So there was a lot of interface now with different people, and making a decision about whether or not we should accept the risk of this new group. And if so, then what should we price? And then also doing renewals. So looking at some utilization information with different groups, larger groups, and determining what we should be charging for their new renewal. And then from there, I also learned how to present that information to larger groups. So the marketing department often brought me out with them, and I would explain to an employer group why their rates were being increased to thus and such amount. And I will honestly say it was an excellent experience. So just kind of going back to the Kevin Callahan conversation, I think in the 3.5 years that I was at Harvard, that really, I feel like I did take advantage of just trying to learn what I could learn that would then carry me to the next job. And, looking back now, I can see how that happened in the moment, when you're there thinking, I really want to, instead of going A, B, C, I just want to go from A to C.
Right. Which is what a lot of young people kind of expect.
Exactly,
right?
exactly. But, looking back, I can see, it's even as recently as this week, having our own health insurance renewal here, that experience comes back to me during those conversations. But that was actually a pretty interesting part of the job, going out to groups like the Boston Globe or Harvard University and, explaining why they were getting a 20% increase to their health insurance. The piece I think that the health management degree helped me with that is I was in an environment in the underwriting department where there are a lot of people who are real number crunchers, who had more of a degree in accounting or math, or, people who might even be pursuing an actuarial, degree or certificate.
It's an insurance agency.
Insurance agency. I think the health management background for me helped balance the ability to look at numbers and be able to communicate to other groups, specifically with the marketing department or with those employer groups, to help people understand the numbers behind, the method to the madness, so to speak.
Right. Okay. So you stayed there, like I said, for 3.5 years, and then you decided to leave Harvard Pilgrim and you went to a firm called MedBill.
Yep.
What did you do for MedBill?
Right. So in between, I should also say, in between at Harvard is when I also went back to UNH and received my master's degree.
Okay.
And so that was also part of my plan to say, I want to move on from here. What do I need to help me move on from here? And so...
So you did an MHA.
I did an MHA, yes.
You don't have that program anymore.
Correct.
So
Correct.
what is an MHA? What was the MHA program like at UNH at that time?
So at the time, it was in the health management department, and it was a Master's of Health Administration. And because they were relatively new, they were able to count my undergraduate degree as my first year.
Okay.
I think you had to be enrolled within maybe 2 years or 3 years of graduation for that to count. And it was an executive style program, so I could continue to work and Fridays and Saturdays off and went to school. So it was fairly intensive, but it was a great program. It was residential, which was a little different for me because I commuted during my undergraduate. So I made a point of going and staying for those weekend retreats, so to speak. So that degree helped me to move on from Harvard Community for sure.
Okay.
So when I went to work for MedBill, it was a company, MedBill is a subsidiary of Coastal Healthcare Group, and that company hires emergency room physicians, typically in areas that have a hard time finding emergency room physicians, so either very rural hospitals or real inner city hospitals. So my side of the business, the billing side of that, where we would bill for the physician services within the emergency department. And then we would determine how much of a subsidy the hospital needed to provide to staff the emergency department, because almost always the hospital is subsidizing for the staffing of the physicians within the emergency room.
Okay.
And so it combined my experience at Harvard Community, where I was pricing, new groups. It also allowed me to then kind of get my foot in the door in a medical institution and be looking at medical records and making a determination about what the utilization would be within this emergency room for the physician visits, what we would be able to collect, and then what they would have to charge for the subsidy. At that particular company, I also was able to do a lot of traveling. So part of that was in my training, because they were a national company, and going to very obscure hospitals,
rural or inner city.
Exactly,
right.
It was super interesting.
Yeah.
And then the other part of it was more my territory. Being able to go to hospitals that were then more in my territory.
Okay. So you got to see a lot of hospitals.
I did.
And see how they operated.
I did, yeah.
That's a unique opportunity.
Yeah, it was super interesting. Even going in this very small hospital in Tennessee, where they were literally waiting, for the local boy, so to speak, to come home to become the surgeon for the hospital. So it was just a very interesting experience, just opened my eyes up differently, than
how it's different in different areas.
Exactly.
Different organizations operate different needs.
Yeah.
And of course, you had your experience as an emergency room
Exactly,
clerk, right?
correct. So, oddly enough, when you think about, again, the experience you get in one job that can lead you to the next.
Right. And
Absolutely. I'm sure that was part of the interview questions.
Sure.
And could speak to operations within an emergency department and being comfortable. Part of it is just being comfortable in your environment. And so that would certainly go, because when they were looking at a new account, I would have go in, to the emergency department and literally go through their billing, and sit down in a room and look at all that.
Right. So you spent about a year?
I spent it roughly about a year. There was actually probably a little less than a year, which is probably the one thing, if I was now I'm in the position of interviewing people, I would probably question that and say, what was up with that? So part of it is I was not 100% sure about the company.
Okay.
They seemed like a solid company, but in this area, they were from the South. They were based out of Durham, North Carolina. So the branch of the company that I was working for was here actually in Portsmouth. Okay. They opened up an office downtown. And they had a really hard time breaking into the, for lack of a better word, the North. For whatever reason, I think the healthcare system in this particular area, Maine, New Hampshire, Massachusetts, presented a real challenge for their business. And I could see that things weren't necessarily growing the way that they had wanted growth to happen. And so I was really more worried about my future, and, where could this go? And again, seeking out the advice of different people in my life, I happened to see an ad in the paper for Director of Social Services and Admission Director here at Edgewood, and called my old boss, who was the rehab director, Susan Kyler. And I remember saying to her, Susan, I feel like I'm at a crossroads. I'm thinking about, my future. She was a person I greatly respected. And in that conversation said something like, I was actually even thinking of applying for this job that I saw. What do you think? And I remember her saying, you know what, I think that would be really great. I feel like you should come back and apply. We'd love to talk to you. Which now, sitting in my seat now, I can see why she did that. I can see why I might do that for somebody who had worked here, who moved on, who, was thinking about something different. And so I guess I would say, in that sense, maybe the rest is history, but applied, came in, talked about my experience I had gotten. And
so the position that you actually applied and eventually got was what again?
It was the Director of Social Services and Admissions Director. And so in that position, the primary focus of that job was really being the admissions liaison to the facility. Okay. So again, it was more, I think the experience I received at MedBill, now looking back, I can see was a step closer for this particular job as the admissions director, because in that job I was going out to the hospital and various providers and reviewing medical records to see if that particular individual was a good fit for whatever bed we might have open here at Edgewood. And so the experience at MedBill, even though it was short, provided me, with that experience of looking at medical records and sort of making decisions about would have billing in that
Okay.
case, but suitability in this case.
Okay. So how big was Edgewood at the time you
At
came
the
back?
time,
And has it changed much?
it's definitely changed for sure. I think what's changed actually is not our size. I will say that. We were licensed for 156 beds at that time. We're still licensed for 156 beds. What's different is at that time, we were probably running with about 156 residents. Today, we run with about 135. So the difference is really more about the mix of the types of services that we provide. And that has really been as a result of the changing healthcare climate. So at the time, I'd have to go back in my memory, I think the hospitals may have been relatively new with DRG reimbursement. I definitely remember at the time, we were the only game in town. So we were the only skilled facility in Portsmouth. So we was either Portsmouth, Dover, or Exeter. So people at Portsmouth Hospital literally at the time would wait in the hospital for Edgewood to have a bed to open up. And so life was much more predictable back then. I would know I have a discharge coming up on Wednesday. It's Monday. I can go to the hospital. I can see who might be ready on Wednesday. They would wait for that bed to be open on Wednesday. I would have known who's coming in a day and a half ahead of time. I would have met that person, met the family, coordinated everything, and then they come to Edgewood.
Okay.
Today, things happen much more rapidly. The competition is much more fierce, so to speak. We're not the only game in town.
So the competition, by that you mean other skilled nursing
facilities
that have the ability to take these patients from the hospitals.
Yes,
Okay.
Exactly.
Okay.
Absolutely. And so decisions are made much more in the moment. We may come in the morning with, no available beds, and then 2 people decide they're going home, and then the hospital's given us 3 referrals we never heard of before today. And so, the years of, being able to schedule an admission, it's really almost laughable at this point. Like, you never know a day and a half ahead of time. Okay. You're often just knowing right in the moment and needing to make those decisions, right then.
Can you talk, you mentioned the idea of a DRG. Can you explain what that is and why would that have changed the relationship between the skilled nursing facility and the hospital?
Yep. So, sure. So my understanding is that DRG is diagnostic related groups, and changing the way the hospital is reimbursed so that they are reimbursed more on a, I don't know if global is the right term, but basically kind of a lump sum based on the discharge diagnosis of the individual at the hospital. And so if the person stays there 10 days or 3 days, I don't know if it's still the same, but at the time, the reimbursement was the same. And so when they changed to DRGs, the motivation or the financial incentive was to move that person out of the hospital sooner. And so the days of a person waiting in the hospital for Edgewood to have a bed, just those days quickly came to an end with the changing reimbursement. And frankly, it's better for the patient anyway. Overall, I would say improvements, the competitive environment, it's all good. It's all, I think, patient has definitely benefited. There's no question. Additional choice is a good thing for the consumer, as an example, And it's not a bad thing, to move a person on from the hospital to a setting like ours and to home sooner. Everything happens quicker.
Right. So a skilled nursing facility, what does that do? Why the handoff from the hospital to a skilled nursing facility?
So it's really a bridge often between the hospital and home. I think the benefit from the patient is it's often sort of a little graduation, so to speak, from an acute care setting where the focus, again, this is just my perspective only, but I think the focus is about, that immediate situation that brought the person to the hospital, the fractured hip or the pneumonia or the stroke or whatever it was that happened at home that landed a person in the hospital. That's the focus of that hospital stay. And then when a person is stabilized, then it's appropriate that that person then go to another setting where then they can carry that care forward. What's been done to stabilize the person, but now what are we going to do to help bring that person to the next level, whether that next level is home or a different care setting, or in some cases, whether that care is in a long-term care setting. It's really that bridge. And so the skilled nursing facility is a Medicare term. And so Edgewood has participated in the Medicare program, really, I think, since we were initiated. Our services initiated in 1972. I think we've pretty well participated in Medicare since, way back then.
Okay.
And it just refers to a level of care for an individual and their ability to access the Medicare system
Okay.
while they're here.
So you were the director of admissions and rehabilitation. Is that what you
A
said?
social services director.
Social services.
Yes.
So the other aspects of what you were doing
Yeah.
include what?
So basically would include the, kind of social work needs of an individual. I wasn't the social worker per se, but I was in a position now of supervising the social work function for the facility. So needing to really become more involved with what that means, resident rights. What is the role of the social worker from what we might think of more traditionally as a supportive role, for a psychosocial supportive role for our residents, to also the financing side of it, helping a person access benefits that they would have available to them, and helping, the facility manage that, care planning, assessments, that end of things.
Okay. And so how long did you do that for?
It might have been about a year.
Okay.
Maybe less than a year when I was in that role,
Okay.
that, I knew I had my mind into doing an administrator in training.
Okay.
And so even when I applied for the position, thought this is then one more step closer to really where I want to be.
Okay.
And I should back up, because when I was at Harvard Community, when I left Edgewood, I knew pretty much immediately that I always wanted to come back into long-term care.
Oh.
Like, I think when I first graduated from UNH, I had this idea that I really always wanted to be in a hospital. My experience here as a rehab aide, at the time I might not have known it then, but when I left here I knew it, that it really showed me that setting is really where I wanted to be. So
what was it about it that made you so sure about your future? Or really drew you, because you didn't get to it immediately.
Yeah,
Okay.
so I would say definitely the people, the residents specifically, the older adults, the families. It's a passion. It's a calling. I don't know how else to say it, except I don't think, again, I knew I loved my job as a rehab aide, but I didn't know that at the time this was really where I wanted to be until I left and thought, how is it that I can get back there? Like, what can I do to get back there? And I'm finding myself, as I'm saying this to you, realizing that I'm a person who has sought out advice over the years, because I remember going back to UNH and having conversation with professors, about how can I get from, again, that A to C? How can I do that? And I remember having a conversation about how that master's degree may help me bridge that gap. I can definitely see that it did.
Okay.
I think I felt at the time in the insurance world, I was doing very well. I believe that I was well respected. I felt that when I was there, and I certainly received that feedback. So I could have seen my career, going in that direction. It just isn't where I wanted to go. And I felt like, I was going off to the left, so to speak, and I really wanted to be over instead of left field, I wanted to be in right field.
Right.
And needed something to bring me there. And, again, the master's degree helped me to do that. So when I made that application back, to Edgewood, it was a lateral move. I didn't go up the ladder, salary-wise. It was definitely just an even exchange, which was really, really okay with me, because I knew what I was getting was opportunity, and I was coming back into a setting that I just really loved. And so for me, I guess professionally, if you were to look at like job grade or whatever, however you want to evaluate that, it was probably more of a lateral move, but it really wasn't for me personally.
But it was in the right direction.
It was definitely in the right direction.
Back into left field or
right field, yeah.
Whichever one it was you
exactly.
wanted to be in, right?
Absolutely.
Yeah.
And so again, thinking, maybe they would let me, do an administrator in training. And so I think maybe I was about a year in the job, or maybe not even quite. And I asked, would this be ever possible, for me to do an administrator in training? And Patty Ramsey, who's the current owner, at the time was the licensed administrator as well, said, of course, absolutely. We would always want to give, opportunity to someone who's wanting to take advantage of that. And, she allowed me to pursue my administrator in training.
So what is an administrator in training?
So an administrator in training is, by regulation, in order to be licensed as a nursing home administrator, in addition to other requirements, an individual has to complete an administrator in training program. The program varies from state to state. In New Hampshire, the program is a 12-month program. In other states, I know that in Massachusetts and Maine, it's 6 months. It may be as small as 3 months in other states, but I'm not totally familiar with that. But in New Hampshire, they're pretty strict at keeping to 12 months. And so the idea behind that is that you would basically take that period of time and learn what you need to learn in order to be able to function as an administrator. Things to include regulation, nursing home operations, just the variety of issues that might come up in the course of time. And I think the idea behind the 12 months is and I can see that now again looking back, it would be hard to experience the variety of issues that come up in a 3-month period of time, because the variety of issues that come up are so vast that it's likely that it would take 12 months before that issue might come up. It might be 3 years before the issue comes up, but I'm thinking that's why a 12-month period.
Okay. And do you take an exam as well?
Yes, you do. So there's both a federal exam as well as a state exam that individuals need to take. And even backing up further than that, when you're interested in pursuing, the Board of Examiners for Healthcare Administrators will send you a packet. And in there, it will include a checklist. And the checklists are all of the things that you're to learn during your administrator and training period. And your preceptor signs off that you, in fact, learned these areas. There's also a course requirement, areas that you need to have formal study in. The health management degree satisfied all of those requirements. In addition to that, there are things like a criminal background, letter of reference, application that needs to then be submitted to the board. And then the Board of Examiners approves your application, and then you're ready to sit for the state and the federal exam. Obviously, the federal exam would carry state to state, and the state exam, for obvious reasons, varies. Yeah.
State. Sure.
Yeah.
Sure. Okay.
Yeah. And at the time, it was offered, I think, twice a year. Now, I think with technology, I think they can administer the exam on a rolling basis.
Okay. So this is a status rather than a particular position, or is it a particular position?
No, I would consider it like similar to being a licensed nurse.
Okay.
So the licensure travels with you,
okay,
as opposed to a position within a facility. So theoretically, you could be a licensed nursing home administrator and not be currently working, I guess, as an administrator that would travel with you.
So it's a credential that
a credential,
that you get,
exactly,
rather than a particular position.
Exactly.
Okay. So you were interested in getting this credential. You were
Yes.
still working in the admissions director position.
Yes.
And so how did your experience and your internship opportunity, how did that integrate with your day-to-day duties?
Yeah, it's a good question. So you got to put in your own time.
Okay.
With anything else, I was having a conversation with someone the other day, and I was thinking, well, you know what, really, when other people were going out at nighttime, I wasn't. I was studying, or I was trying to be here learning beyond, my regular full-time job to be able to learn the things I needed to learn to be an administrator. So there's definitely a little bit of personal investment that has to be put forth, which I think is important, for anything. But that was important to me, so it was worth it.
So who was your preceptor?
My preceptor was Pat Ramsey.
Okay.
So there's some requirements about who can be a preceptor and the size of the facility that you can do your administrator in training in.
Okay.
Certainly the length of time, as I mentioned, the number of hours, that kind of thing.
So what did she tell you had to do, or how did you organize the internship experience?
It's a good question. So the information from the Board of Examiners helps you kind of walk through that, because you have, there'll be a statement about, example might be financial management. And there's probably, I have to go back in my memory now, but I'm sure there's some kind of statement like that the applicant has a thorough knowledge of, Medicare, Medicaid reimbursement. I mean, it probably doesn't say exactly this, but something along those lines, that would verify that the person applying, to sit for the exam has been exposed to, has spent time learning about reimbursement issues and financial integrity and that end of the nursing home operation. There's also a clinical side as well. And in fact, again, that experience that then helps you get that next job, going back to that theme, I was actually able to waive 3 months of the AIT based on my clinical experience as the rehab aide.
What is AIT?
The AIT is the administrator in training.
Okay, so 3 months of the 12-month training period
was waived.
Oh, okay.
And so I had to apply for that to explain that I had worked at Edgewood, I worked as a rehab aide, I had gained this experience as a rehab aide, and based on that, would you consider waiving
the board
3 months? And the board can do that. My experience with the board is they almost will never waive more than 3 months, and so I appreciate the way New Hampshire handles that.
Okay. So you started pursuing this internship role
Yep.
while you were the admissions director.
Yes.
And how did your career path progress from there?
From there, well, first and foremost, I think with any job, you need to prove yourself. You need to be confident. And, again, being in this position that I'm in now, I can see how important that is, how important a person's integrity, dependability, personal effort really means to leaders as they're evaluating who they want to provide opportunity to. All of those things really matter. And so there was some kind of dovetailing, because at the time, being in my position, I was also being exposed to operations within the nursing home. That's a department head level position, so now I was going to department head meetings. I was learning, even just through osmosis, how the nursing department operates, what's happening in food service. Here at Edgewood, when a person is interested in learning about other areas of the business, we're all for that, and showing interest in wanting to learn about operations in general. It was sort of like a blank canvas, for me to be able to learn. And then at one point or another, I was promoted to be the associate administrator of Edgewood. And so in that, then I was just exposed a little bit further. I think I might have then shared being on call with Patty, who was the administrator. So from an administrative standpoint, opening up just more opportunities for me to be exposed to different situations.
So now we're using administrator not as a credential, but an actual position.
As a position.
Okay. Describe a bit the organization of Edgewood then, since because you started to talk about there's some departments.
Yep.
So give us a sense of what is the hierarchy and structure of the organization?
So I think probably similar to other long-term care facilities, it's pretty flat.
Okay.
So we have an administrator who is the person who's basically overall responsible for the operations and maintaining, compliance with regulations and so forth. Then there are roughly about 11 or 12 department heads that report to the administrator, and then managers and supervisors within those departments that report to the department head. Okay. Most of the department heads are working positions, and some not so much. Like the director of nurses is not she doesn't take a med card every day. She's more in a supervisory leadership role, as opposed to our child care director, who may teach in one of the classrooms during part of the day, as an example. But basically, that's really it. I mean, that's your management team. Okay. And so from my perspective, the folks within the department head group are really extensions of administration. So we try very hard here to have a level of consistency with leadership and philosophy and adherence to just different compliance issues amongst the department head team, so that any one of us could address certain issues or be aware of how things should be done, so to speak, and to just help throughout the whole building. Okay. I should also back up, because we're independently owned, then we have an owner who's, really, who I report to, who, to our benefit, is also here every day. So at the time that I came back to work here, we had two owners of the facility, Patty and David Ramsey, brother and sister. Their father built the facility in 1972. They took over the ownership of the facility in 1985. Patty was the administrator at that time, and David was also one of the owners here also every day. And then Patty was the administrator until, I believe it was 1995, when I became the administrator, and she maintained her ownership status and also was here pretty much every day. She was raising a family, so that changed her dynamic a little bit. And then in 2003, she became the sole owner of Edgewood. And so Patty and I would say, really, we complement each other. She's also a licensed administrator and has maintained that status. So we really, again, complement each other in that role and in just leadership of the
So you share leadership tasks?
We share leadership, for sure.
Okay.
Yeah.
How did you said you were really, you were sure, reasonably sure, even before you graduated, that you wanted to ultimately be in long-term care. You took that kind of
the detour.
A detour into insurance
and
operations, but you made your way back. But there's lots of opportunities in long-term care. Why did you stay at Edgewood?
That's a great question.
Because certainly once you got your credential as a licensed nursing home administrator, opportunities must have, and probably still do.
Absolutely. Why stay here? Well, so I guess first and foremost, Edgewood is a very special place, and I think I feel confident in saying, if you talk to many, many, many people here, they would have a similar reaction. I think I could get emotional, talking about why I love this place so much, and certainly my relationship with Pat Ramsey, the owner, goes far beyond, a employee-employer kind of relationship. It's definitely very a deep connection, and I just don't think that you can replicate that always. And for me, that need, there's certainly the job, and there's what I love doing and being with the residents and all of that. And yeah, I could probably get all of that in a different nursing facility because, when I visit other nursing facilities, I love being there too. But I think it's about the people that I'm able to work with here that really would tie me deeply to Edgewood. I was having a conversation with Dr. Thomas of the Eden Alternative. I don't know if you know Bill Thomas. Okay. He's a very interesting person in and of himself, but he was locally, he was here last summer, and he came to Edgewood. And I said to him before he toured the facility, I said, I just want to let you know that I pretty much know that I have the best nursing home administrator position worldwide, and I want to tell you why. The why is because there's just not a finer person than Pat Ramsey. I mean, there just isn't, period. Miriam Pelletier, our director of nurses, and I just couldn't even imagine doing this job without her. She's incredible. Our medical director, Sarah McDuffie, came on board by a kind of a strange twist of fate, but one that benefited Edgewood immensely, probably about 3 or 4 years ago. At that point, when she came on, in my own mind, I officially declared myself as having the best position. And when Dr. Thomas came, knowing that he had experience, in other nursing homes, I told him that. And we toured Edgewood, and I introduced him to the people that I had referenced. And as we were leaving, or he was leaving that day, he looked at me and he said, "You're right. I just want you to know I can officially also declare you have it."
Oh,
and I thought,
that's nice.
Absolutely. So what I know is it could never be like this anywhere else, because it couldn't.
Is that just luck, or is that a culture that Patty and you have worked towards? Or
I'm going to actually quote Patty on that.
Okay.
I'm going to quote her because she was interviewed a few years ago for an article about this very thing. And one of the quotes that really stayed with me that she said is, it may have taken a number of years to kind of get where we are with our management team and so forth, but her words were, what she hopes is that wasn't by mistake, that was through, hard work, deliberation, thoughtful thought process about, who was in the right position and so forth. The other part of that is just because Edgewood is Edgewood, we're independently owned. Patty's here every single day. That type of system is really one of a last of a dying breed in long-term care. So for that reason, I think it couldn't be replicated. And I've not worked in another nursing home. I've not worked for a corporation. What I know is there are positives and negatives to each kind of scenario. What I think works for us here at Edgewood is that closeness to our client, the fact that we can be very nimble when we're making decisions, that what I know at the end of the day is that Patty's motivation in owning the facility is only ever to do right by the elders. There's not a personal interest in personally getting ahead, which, yes, we're running a business and we have to always make sure that we're running the business in a sound way financially. And also, that is also done in only the most ethical, highest integrity way that, I know I can feel really good about. When sometimes we have to make hard financial decisions, what I know is that they're always done for all of the right reasons. And not to say that they're not in other settings, they probably are too. I think just having that closeness with the owner, the operations there, I think it probably has a different feel.
Okay.
If we have to make hard decisions like going on a wage freeze, and I have the owner of the facility sitting next to me and delivering that message to the staff, I think that's a different statement than if that decision was made out of state by other people. Do you see what I mean? Mm-hmm. It's the same decision, but it's just different.
Right.
That's all.
Sure. Well, it comes with a different kind of cultural
It just
effect,
does,
right?
yeah. I don't think you can, there's just no way around it. It just does.
So you have 6 types of service that I was looking at on your website. I thought maybe we'd walk through
Sure.
each of those quickly.
Yeah,
and
sure.
so we get a sense of, for those people who are not familiar with, my sense is these are common service lines for long-term care, but for folks who are not familiar with
Sure.
long-term care organizations. I thought we'd start with talking about short-stay rehab. What is that?
So short stay rehab is really for a person who's had some type of an acute event that has landed them in the hospital. Typically speaking, it's a straightforward joint replacement. Somebody's gone into the hospital, whether they've fallen or whether it's a pre-planned hip replacement or a knee replacement, and they need to come to a facility like Edgewood to get back up on their feet and go home. And so the short-term piece of that, can be anywhere from 1 week to a month, depending on the situation. But more often than not, the person's coming for intense rehab, nursing care, and then they're going home.
Okay. So let's say I knew in advance I needed to get a hip replacement. I might get my surgery done at Exeter.
Yep.
And then before I even go in for that, I might have picked from amongst the various long-term care facilities that offer short-stay rehab where I want to go.
Correct.
And be discharged from the hospital to...
Exactly.
And so then you do what with me? Let's say I got a hip replacement.
So you're going to come in. The first day is always really intense. You've got your nursing assessments, your rehab evaluations, and so forth. And then basically a plan of care would be developed, with you. Typically speaking, in that case, nursing would be responsible for sort of the overall care management, medications, interfacing with the doctors, pain management, that kind of thing. But your primary focus is probably going to be rehab, getting back up on your feet. Edgewood has our own in-house rehab department, so all of our employees are Edgewood employees as opposed to contracted. And so a person would be receiving physical and occupational therapy anywhere, from a couple of hours to many hours in a day, depending on the specific diagnosis and need and ability to participate. We also have speech therapy if that's appropriate for an individual. But your days pretty well are full.
Yeah.
They're full with receiving therapy and then recovering. People are tired.
How does Edgewood get compensated? Is that also like on a DRG kind of program, or is it a daily fee? Or?
It's a good question also. So we are on a prospective payment system. And so basically what that means is we have assessments that we complete for our residents. That's a standardized tool. It's a federal tool, the minimum data set. We refer to it as the MDS. There are regulatory compliance issues with completing the MDS and the development of a care plan and so forth that are separate from reimbursement, but they use the same tool also for reimbursement. And so we complete that tool, and then a person's care is summarized in one of, I believe, 44 different resource utilization groups. And we are paid a different rate based on the the RUGs, RUGs grouping.
Okay.
And so theoretically speaking, they're looking at that assessment that we've completed. They're summarizing the care needs into one, of 44 categories, and with each category is a different rate that would then, compensate us for all of the resource, that's going into caring for that person.
Okay.
And then that MDS is completed at different intervals, which equates to different periods of time that we've reimbursed.
Okay.
So the other part of that is just to clarify that's for a Medicare recipient, which is, by and large, the bulk of the residents coming in are covered under the Medicare program. However, I would also say that that's also been a big change over the years. We have more and more managed care companies that we're working with, more and more Medicare replacement plans that we're working with, and also just additional Medicare regulations that can impact a person's ability to access coverage. And so part of what we do within our facility, but all throughout all long-term care skilled nursing facilities, is to try to have a really good handle on the Medicare guidelines and what will allow a person to be covered and what won't allow a person to be covered. And I have found over the last 3 or 4 years that's just all becoming more complicated.
As a result of changes coming from the ACA?
Coming from not so much the ACA, I think, although it probably all really goes together because I think it's all about cost containment. Mm-hmm. And so Medicare has initiated just additional audits, for lack of a better term. When we accept somebody under the Medicare program, we are expected to know what the Medicare guidelines are and to know when a person should be on Medicare and when a person should come off of Medicare. We're responsible for interpreting that and delivering that information to the beneficiary. If Medicare pays us, Medicare also has the ability to go back, request a chart review to see if we got it right. If we didn't get it right, Medicare takes that money back. That's been always there, that they have the ability to do that, but they've really heightened the frequency with which they're looking at that. And so in the past few years, I found myself having to really become more involved with appealing, Medicare decisions and understanding the guidelines in a different way than I had before.
Okay. You also have listed skilled nursing. How is skilled nursing different than short stay rehab?
It's really basically the same.
Okay.
So when you qualify for coverage under Medicare, you are able to be covered either for a skilled nursing need or a skilled rehab need, or both.
Okay.
And so we do have people here who aren't able to participate in therapy, who are still able to access their Medicare benefit because their skilled nursing needs qualify them. A simple example would be somebody who has a wound, that's requiring a daily dressing change of a certain stage, or IV antibiotics or something like that.
Okay. And they'd be admitted here because they couldn't get the care at home.
Correct.
They didn't have a home environment where that would be conducive to having that care done.
Correct. Or it's not practical to deliver that care at home. If a person, for instance, with a wound, maybe they need the wound changed 3 times a day, the dressing. That's not something that's going to be able to be done at home.
Just so much to be done. Yeah. It just makes more sense to just do it in a facility rather than trying to.
Correct.
Okay.
Yeah. So part of what we have to do, too, is to balance those costs. So when we accept a person under the Medicare program, Medicare, when we went to the resource utilization groups, also included more items related to a person's care that we are now financially responsible for. And so part of what we have to do is also manage those resources. And so that has been a change, over the years. It had been in the past more of a fee-for-service. So if a person was on a high-cost antibiotic, that wasn't necessarily an issue because we would get that reimbursed, whether, it was immediately or a few months from now, we still would get the money. Now, not so much.
Is it considered rolled into the...
It's rolled in, yes. Okay. It's absolutely rolled in. So, again, when I say staying on top of the Medicare kind of guidelines, that's sort of included in that for me is, the cost of certain items, what care needs a person's going to need, while they're here, and our ability to balance acuity levels, within the building to make sure that we're also going to be operating in a financially sound way.
Okay. So you have short-term rehab, skilled nursing, and then you list long-term care. So what's long-term care as opposed to, say, short-stay rehab?
Yep. So long-term care would really be when a person has made a decision that Edgewood is going to become more their living environment. And so we have 2 long-term care units with about 50 beds apiece. And we have 1 short-term unit, has the capacity for 50, but we really run about 35 because we've made so many private rooms over the years. And so the bulk of our business actually is long-term care. However, I would say, let me rephrase that, the majority of the residents who are here on any given day are here for long-term care, but the volume of intensity with regard to the services we provide tends to be around the short-term population because it's more abbreviated, it's more intense. But most of the people coming into the facility being admitted come in through our short-term unit, and then sometimes with the idea that they'll need long-term placement after a short-term stay, and sometimes, for whatever reason, they just aren't able to return to their previous living arrangement. And so people then convert to long-term care. And so we have an area in the building that more specializes in dementia care, and an area in the building, and I talk very much in general terms. Simply put, we do have residents with dementia throughout the whole building, but just more services concentrated for that population in one area, and one area of the building where more of our residents are more alert and oriented, are able to let us know what their needs are.
Okay. And so both are enrolled in your long-term care.
Both are long-term care
services.
Correct. Okay. Yes.
You also have end-of-life care and respite care.
We do.
Talk about those
yeah, sure, we
services?
do. So I'll talk about respite first. Respite care has been a wonderful service for people who are living in the community who just need a break, for a variety of different reasons. So, maybe a caretaker who's taking care of a loved one at home who's, things are going along very well at home, but who may need medical care of their own. We've taken people in respite while somebody else goes into the hospital for surgery, maybe going on a vacation, maybe just need a break or have family coming in. One of my favorite examples of respite was a new experience for us just this month. We have a gentleman here for respite. He's actually from, I believe, Arizona, and he's come out to visit family in this area, but needs care. And so they contacted us to see if he could be admitted to our facility while he was here visiting them, which was just a little different.
Okay.
So respite meaning more short term. More traditionally it's to give somebody who's a caretaker at home a break, while we're providing respite. But in that case it was, maybe a little bit of a vacation for somebody coming to visit a family. It was, it was kind of interesting. He's here for a month.
Okay. And how does one pay for, is respite typically a out-of-pocket kind of
Typically
arrangement?
speaking, respite is out-of-pocket. We also contract with the VA.
Okay.
And so, for that particular gentleman, the VA is involved, and the VA is paying for a portion of his stay. The state also has a respite program through, I believe, their HCBIC, Home and Community-Based Waiver.
Okay.
We've not participated in that of recent years, but we have in the past. We also offer respite through a couple of different hospices that we contract with. And so again, for a person on hospice at home with a caretaker, and that caretaker needs some type of a break, whether for their own health or whether just because, and then the hospice would be paying the respite.
Okay. And then the other element related to hospice is end-of-life care.
End-of-life care, which I would say is an area of real specialty, I think, for Edgewood. And I would say, probably throughout long-term care, for maybe obvious reasons. It's certainly something that we deal with on an ongoing basis, and I feel as an industry something that we do very well, both caring for individuals at end of life and also their families at end of life. And so it's not uncommon for us to have a referral for somebody specifically for end of life care, whether they're coming directly from the hospital or home, in a home situation, or certainly one of our own residents who has maybe lived here for a year or 2 years, who is now coming to the end of their life. However, that transpires. End-of-life care is something that we do very well. Dr. McDuffie, our medical director, also happens to be the palliative care director at Portsmouth Hospital, so naturally kind of brings that philosophy and that carryover, from the acute setting, here, to our facility. We contract with 2 hospices and are available to accept their patients, again, if they're at home and they just need more 24-hour care, or if there are current residents who are then become hospice appropriate, and we work very closely with those agencies.
Okay. Related to kind of your services, I asked you this specifically on a couple of them, but payment. It's got to be a complicated issue because Medicare, many of your patients are Medicare eligible, but Medicare has a limit on the number of days that it will pay. So what is that limit, and kind of how do you
How does
work
that
with
go?
that?
Sure. So the limit is 100 days.
Okay.
And so what we generally tell people is that almost nobody gets 100 days. And we find ourselves almost in a position of continual education around the Medicare benefit. And part of it is very black and white, and part of it is a little bit gray. And so oftentimes people hear 100 days Medicare benefit and they assume they're getting 100 days of coverage. And again, almost nobody gets 100 days. Within those 100 days, you have to meet certain criteria to be eligible for reimbursement under Medicare. The black and white part of it is that an individual has to have had a 3-day hospital stay within 30 days of admission to a skilled nursing facility. So if you haven't had 3 overnights as an inpatient, not as an observation patient, but as an inpatient, then it's a definite no. You can't access your Medicare benefit. So if you've had 3 nights as an inpatient, then it's a maybe. And then you look at the clinical presentation of that person to determine if they would meet Medicare guidelines. And Medicare will pay, for persons participating in rehabilitation and for skilled nursing care. And that's where it can get a little bit gray, because then, what is that? If a person needs the daily intervention of a licensed nurse to carry out whatever plan of care is in place, then again, they might qualify for Medicare, but not always. So We have found, to a degree, in the past 2 or 3 years, that's been a little bit of a moving target. And also with the introduction of managed Medicare, we found ourselves in a position where we believe Medicare would cover, X, Y, or Z, but the managed Medicare company is saying no. And that's been an interesting dynamic for us. And the reason we've come to really delve into this a little bit further, the 2 reasons. One is Medicare has beefed up those audits. So we've had to not only provide records, but really fight, for why we feel this person met Medicare criteria. That has, for lack of a better word, it's made us really understand those in a more thorough way.
Okay.
The other part of that is just with that consumer, maybe being more knowledgeable or, searching out answers. We have found sometimes having to just re-educate that consumer as to exactly what the Medicare benefit really is. And it's not uncommon for us to be in a meeting with a family member saying, no, I was told my father gets 100 days, and what do you mean?
Right.
And so there's some difficult conversations that happen, here.
Yeah.
And so
if Medicare doesn't pay,
then what happens? So then what happens, basically, in a nutshell, is a person either pays privately to stay here, or they need to make applications to the state for assistance. And so, again, with that, in a nutshell, the quick and easy way of saying how that's determined is in New Hampshire, there are 2 criteria that have to be met in order to qualify for state assistance in a nursing home. One is medical. So it's not like just anyone off the street can just check in and then the state pays. You have to meet certain medical criteria for the state to say, okay, you're a nursing home appropriate. That has to be met. And then the other is financial. And both over the years have gotten a little bit murky, but more so in the financial area. And so financially speaking, in New Hampshire, a person can have no more than $2,500 in liquid assets in order to qualify for Medicaid. So again, quick and dirty, if you've got $50,000 in the bank, you have to spend down the $50,000 to be no more than $2,500. And then you might, capitalized, bolded, exclamation point, might be eligible financially for Medicaid.
Okay.
And so the might encompasses that evaluation that the state does in terms of a person's personal finances. There's a 5-year look back, and they...
if you were giving away assets
correct,
in order to be...
exactly. And that's where I would say over the last at least 5 years, and it seems like every year even more so, that has become more complicated. And so...
What about something like a couple and one of the spouses gets admitted,
yeah,
clearly needs to be in long-term care, they own a house that's worth $200,000.
Yep.
What happens?
What happens then? So based on our experience, the state does not have an interest in impoverishing the spouse, what we would call the at-home spouse. So they really wouldn't go after the house or expect that the person sell the house, which is an often or common fear. I was just speaking to a family member a few days ago. Her dad is here, mom lives in the house, there's co-ownership, and she's fearful about her father staying here for the state coming and taking their house. So while we can't say firmly no, what we can say is our experience is the state doesn't do that. I don't even believe necessarily that they've been attaching a person's house, but I could be wrong on that.
Okay.
But that fear of, mom's going to have to move, we have to sell the house and liquidate, that's definitely not our experience. Our experience is that our state wants to keep that at-home spouse whole. They don't want that person being on the street, and they would then look at more of the liquid assets, and that's, again, been our experience. And so our experience also is that they would look at that and make a decision about what's the mom's asset, what's the dad's asset, and then the dad, if the dad is the one that's here, would spend down only that portion that's determined to be his asset.
Reasonably his asset.
Exactly. And so we have often found that fear going into it isn't always necessary. I don't know if it's just New Hampshire, but I feel like New Hampshire's pretty reasonable that way. They have definitely beefed up that 5-year look back, and that's where over time I think things have gotten much more complicated, because I don't know if it's just a sign of just the economy that we're all experiencing or whatnot, but we've definitely been in situations where the state has looked at transfers of assets, even innocent transfers of assets, and I'll talk about that in a second, and determined them to be ineligible for Medicaid. So now we have a person living here. They have no money to pay. Let's just say they've spent down. They're applying to the state. There's nothing available cash-wise. They apply to the state, and the state determined that 3 years ago, this is based on a true story, 3 years ago, that person gave $10,000 to each of their grandchildren to go to college. Now that's an inappropriate transfer of asset. And now we've got, I'm making up these numbers, but now we have $50,000 that the state has said is an inappropriate transfer of asset. They impose a penalty period, which means this is the period of time that the individual is ineligible for Medicaid. So for $50,000, it would be a year, I would say, because they convert the $50,000 to an average Medicaid rate in the state, and then convert that to a length of time. So I would say that's at least a year that the person has no money and is ineligible for Medicaid. And so now we as a nursing facility, what do we do with that? Because the person's in our care. We can discharge a person involuntarily based on an inability to pay. So we can do that. We can pursue that, I should say, because there's also a secondary reg that says you can't discharge a person without an appropriate discharge plan. So on the one hand, you have a person living in your building who needs to be living with you. Otherwise, they wouldn't be there. I mean, let's face it, nobody's checking into a nursing home unless they need to be in a nursing home. And they have no ability to pay. Do you discharge that person? What's the appropriate discharge plan? Where do we go from here? And so that's a tough situation. I didn't have the right answer. I mean, we've been in a couple of situations that thankfully at the end of the day ended up working out. But, you're always worried about how that's going to be working out.
Do you have a lot of bad debt as a result of those sorts of situations?
We can. I mean, a lot. I don't know how to determine a lot, but we have, it's not infrequent, that you have a situation like that. I can, right now.
That's got to be a common occurrence for long-term care facilities.
Yeah, it's not uncommon. Statewide, you would have a room full of people talking about the subject if you wanted to talk about the subject. Okay. Yeah. And different, if you combined us, it would definitely be a lot. I think the hard part is a nursing home can get into real financial trouble very quickly. I don't mean, when I say financial trouble, I mean with a specific individual. I mean, the debt can climb very quickly with an individual because the average, rate, private pay rate for a nursing home is, say anywhere from $9,000 to $10,000 a month. So even though a month may not seem like a long period of time, you could be $10,000 in debt at the end of a month, at the end of 6 months, which isn't that uncommon for the state to take that long to determine these kinds of issues, particularly when there's a trust involved. Now you've got $60,000 worth of debt. That's a lot of money. And so it's hard. On the one hand, we're all in this business because we care and we want to be providing care. On the other hand, what I also know is, we have a staff that we need to make sure are able to continue to get raises, and we also want to make sure that we're running things in a way so that we're not overcharging private pay people to make up for this shortfall, and it can be difficult to have those conversations, or people who don't quite understand the fact that Medicare doesn't cover forever. You either have to pay or apply for Medicaid. There's no in between. There's no, unless you have a long-term care insurance policy, there is no other alternative to paying the bill, and I think it's sometimes hard for people to realize that there isn't an insurance plan, federal insurance plan that's just going to cover long-term care.
Yeah. So you bring up a point I wanted to ask you about, and that is long-term care insurance. Do you see a lot of people coming with that, or is it primarily state payment that you're seeing?
Yeah, we don't see a lot of long-term care insurance policies.
Why not? I mean,
I don't know.
We're getting old. We all kind of count on getting old.
I don't know the answer to that, except to say I think people just put it out of their minds and think I'll never need. Yeah, we definitely don't see a lot.
Okay.
When we do, sometimes they're wonderful and they would appear to cover the full, cost of care, and other times we've had situations where they cover more than Medicaid but not quite the private pay rate, and then you're sort of in this in-between stage. So you have to be really careful when you buy them, to make sure it includes a proper inflation factor and, the right kind of coverage that you might need. So, I don't know. It's amazing to me sometimes the people who really did excellent planning, like this family that just the other day showed me their insurance plan. I was super impressed, at the coverage and the daily rate, and I don't know what the answer is there.
Okay. What other big trends do you see in long-term care in the 20 plus years you've been doing it? What do you see on the horizon that's going to change the way things are done?
I think there's real hope for our industry to be just, when I say proving our worth, we know our worth to the healthcare system. What I think is really exciting is that other entities like the hospital or managed care companies or state agencies, I think are going to be looking at the value that skilled nursing, long-term care provides in the continuum differently. And when I say that, what I mean is with the changing reimbursement, if the accountable care organizations, become more fully in this area, I think our value in that continuum will be really more significant because we can offer really excellent service at a really great price. And
relative to the hospitals.
Relative to the hospital, relative to, acute rehab. And not to say, I don't want to make it sound like we're a replacement. We're definitely not a replacement for, certainly not the hospital, certainly not acute rehab per se. There's definitely gray area, in certain settings where a person could go to one place versus another. And I think the value that we can provide, I think it will be really significant. So I would see that really growing. So I think there's real hope there. I mean, sometimes we feel like the black sheep, so to speak, in the healthcare continuum, and I think our value to that is really changing. I think people's perceptions of nursing homes are really changing. I think people are looking at us differently from a quality standpoint, from a need standpoint, and certainly from a value standpoint.
Okay. Let's shift gears a bit and talk specifically about leadership.
Yeah.
And kind of, as the administrator, and as kind of one of the two senior leaders of the organization, how do you set the culture? We talked about this a little bit earlier. Mm-hmm. How do you try to maintain that special culture that you have found here, that attracted you and that has kept you all this time? And now you're in a position to, kind of be the guardian of that.
Right. Well, I think I would say above anything else, I think leading by example is I think what Edgewood, I like to think what Edgewood does well. I guess what I mean by that is I hope that if you ask the staff that they would say that they could see that we love being here too. And I think that's just really important, that passion, for caring for the older adult is evident in all of our leadership. And I think I hope staff would say that. I think they would. I think that really always being mindful of that. I think being respectful of all of the different positions that we have here. There was a staff member once who said it so beautifully, and she said something along the lines of every single position that we have here has really the same level of importance. What we have differently is a different level of authority. And that, I thought, really summed it up because, at the end of the day, to our residents, each and every position here is critical. Like, there's not one position here that's not critical to the delivery of care. And I think respecting that is, I guess, the way we've operated. And so how we do that is knowing our staff. I think both Patty and I are also licensed nursing assistants. And so, not that we work on the floor. I don't want to make it sound like I'm taking an assignment, because certainly I'm not doing that. I would do that if I needed to do that, and have done that many times in the distant past, many times over, taking an assignment because we needed to. But I think being able to help in a way that demonstrates this is what's important here. When I answer a call light, if a resident needs to go to the bathroom as an example, helping, that person in that moment and showing the staff that this is what we do,
Yeah.
I guess I'd like to think that's what's worked for us here, to just, again, be leading by example in terms of that, I think in terms of communication and, I guess I've heard the director of nurses say this many times over, you can always be kind in how we are, even if we're dealing with a difficult matter. Again, if it's a difficult issue with a family member and their finances, or whether it's a performance issue with an employee, we can always be kind. There's always room for that. And I would say we have also adopted a coaching approach to communication many years ago through a grant that we received. Well, I shouldn't say we received, we benefited from through an organization that we were working with. And I think that has helped promote that type of communication between staff members and between, supervisors and staff.
Okay. What do you think is different about leading in a long-term care environment than perhaps what you might have seen or hear about in other healthcare environments?
I think probably, again, this is what I imagine it to be, is that within long-term care, it's a very flat organization. And so, if you're asked, who's responsible for quality improvement? Well, you're looking at her, who's you're responsible for a lot. I would imagine in another type of organization, certainly at the insurance company, they had a whole entire department that did nothing but quality improvement. That's a great thing. There are times I'm envious of that, and other times I'm really glad that's not the case because I love to be involved in a lot of different areas. But I would imagine that's probably one of the big differences. You have to wear many, many hats, and all of our leaders wear many hats, but certainly in my position, in the owner's position, there are just multiple hats that you can wear in the course of a day. And for me, that's what I really love about this job. And I think it is also kind of translated into the type of care that we provide and the different types of residents that we have here. I feel like my job is a little bit eclectic, at times, the types of people that are here, residing here. It's a great variety of people too, so maybe there's a parallel there, that just works. But that's what I would imagine.
Let me ask you quickly about mentorship. Does Edgewood have a formal mentorship program that new people come in and get assigned to? Okay.
That's a good question. So we do within the LNA population, we have a peer mentor program. So people, LNAs who have been trained, gone through additional training and received an internal, certification to be a peer mentor. New people coming in, connected with that person to learn about Edgewood and then learn also about the job, exactly what they'll be doing day to day.
Okay. How much did mentors matter to you in coming up?
It's a great question too. I would say a lot. I mean, even just talking to you today, I can hear myself say, I asked this person for advice or went back to that person. I would say a lot. Yeah, I feel like I'm a person who has definitely sought out advice from people. I just respect their opinion and help me just form my own, if I have a decision that I need to make professionally or other. And certainly here, feeling like I've been in an environment that I've been able to really learn from the people that I work with, and that crosses all levels. I would like to say levels in the organization. I mean, I feel like I feel that I'm continuously learning too from our staff and how they handle situations also. It's a two-way street, I guess is what I want to say. But definitely mentors have meant a great deal to me.
Do you find, are you currently mentoring anyone, both either formally or informally? Do you have young people who are interested in maybe being an administrator?
Yeah, that's a good question too. So we've had interns here from health management over the years, and that's always fun. And we've also had people who have just independently reached out, and we have somebody right now, and I want to say boy, he's really not a boy. He's a young man. And he's going to be finishing up his last semester at UNH, and he has an interest. He loves this population also. Sent me an email, would you consider just an internship, not a formal internship, just because he has an interest and I'm thinking that he's a person who is thinking about his future and getting, resume and experience and so forth. So he, out of the blue, emailed. I said, sure, I'd love to meet with you, met with him, really liked him. Said, you know what, again, Edgewood can be that blank canvas. If somebody wants to come in and is willing to put in their own time and shows initiative, we're all for it. So he came in at the beginning of the summer, and to his credit, he's came in with the idea that this would just be on his own time, unpaid. And, because he showed promise and initiative, we have projects that he can be working on for us that are hugely helpful to us this summer. So he's now being paid. Yeah. And doing some work for us, and we're already talking about what about, is this something, Craig can be doing,
Yeah.
Is this something that might be good for him? Just yesterday, one of our department heads said, I was thinking I'm going to need XYZ help. I've talked to Craig, he might be interested in the fall, maybe we could, work something out. And to me, that's like great. I love it when I love it when young people show interest like that and are willing to just put themselves out there, because something will come up, and it's the same thing with our staff. When we know somebody's interested in, pursuing a different opportunity, it might not be today that we have that different opportunity, but it might be 2 weeks from today. And when we know, we're like, oh, what about, this person or that person? They showed an interest, and let's give it to them, let's give them an opportunity. And I will tell you, I hope that I never forget that somebody gave me that opportunity also, and I do try to remember that. I feel very grateful that I was given that opportunity here as well. And again, I hope I don't forget that. I hope if I do, somebody taps me on the shoulder and says, hey, wait a minute, way back when you were the one who was asking for that. And so, yeah, so we love to have people, and, if we can be a mentor or help guide a person, we're certainly all for it.
So let me close on this final question, and that is, for a young person thinking about a career in health, why should they think about a career in long-term care? And what kind of opportunities are there for someone, say, coming out of HMP or another program like it?
I would say first and foremost, I would not see long-term care going anywhere. I think we're going to change, but I don't think we're going to go away. So for a career choice, I think it's an outstanding career choice. I think that, again, what I really love about my job is the variety of the issues and what I do. And coming out of HMP, I know I was worried about being locked in a, being typecast, in a specific role. For a person who likes that, that's great. There is so many opportunities in healthcare for, a specific type of role. For me, that didn't work. I didn't like that. I like having a broadness to my knowledge about the company and what's going on. So for a person who likes that, this couldn't even be a better choice. For a person who also really likes being around an older adult, again, it just doesn't get any better. I mean, there really isn't a day that goes by that you can't make a difference to somebody, and again, it might just be really minor, but it matters, and when I think about my own life, and, you spend a lot of time at work, and I honestly can't imagine going to a job that I did not absolutely love every day, being the mother of 3 children and being a working mother, coming to a place that I also love. If I was coming to a place I didn't love, that would be really hard for me. And so it's about lifestyle, it's about balance, it's bigger than a job. And I think there's just sort of this fit for every person. And I think one of the things I say in an interview process here, when I'm interviewing a person, I usually interview a person before they're touring the facility. And I say to them, when you tour Edgewood, what I want you to do is take a very long look around, look with a critical eye, pay attention to how you feel. When you walk onto our dementia unit, I want you to think about how you felt when you walked onto that unit. And when you go home tonight, when you're talking about your time at Edgewood with whoever you're talking about, how this day went, I want you to ask yourself, is this a place that I could see myself coming to every day? I'm saying that, and I'll say this to the interviewee, I'm saying that with a real high degree of confidence that people are going to really like what they see. And if people don't, they need to not pursue an application here. And it's okay. It's really okay. People need to love what they're doing, and they need to love where they're doing it. And otherwise, it just shows in everything that you do. And when you're working with an older adult, it's so important that you love what you're doing, because even if that older adult isn't necessarily able to say or tell you that they can tell you don't love what you're doing, they can feel it. And I guess I just really feel like they really deserve people who really love to be here. And so I guess with that, for a person in HMP who has that need maybe to balance out, the business kind of side of operations with that higher mission as to why you're doing it, which I think was my issue with the health insurance plan. It's sort of, I could do that job. I did that job just fine, but it didn't fulfill that other side of me. And for me, I needed that. For somebody else who needs that, I just honestly think there's just not a better career choice than long-term care. So I would just highly recommend it. I would also say you may have to put in a little bit of your own time because of that AIT, and do that when you're in a position where you can do it. So what I mean by that is before you have a lot of long-term debt and you're worried about working for free, so to speak. But for a person who's just willing to just put themselves out there a little bit, there's huge opportunity. So I guess with that, I just couldn't recommend it enough. But for the right person, you absolutely have to love being around the older adult, typically the older adult.
That's great advice. Thank you so much for your time today.
You're welcome. Welcome. Thank you.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.